And we can start with Steve Hoff. The question, how deep do you go with your temperature on hypothermic fibrillation if you have a complex repair?
So when we initially started doing this, the answer is 28 degrees. We've actually cheated a little bit as we've gotten better at doing it and faster at doing it. And as Dr. Lewis said, this becomes much, much more routine and really very straightforward. And so we're now really at a point of kind of using 30 as our lowest goal. We've done patients at 32 or 33 degrees, but my suggestion is as you get started, as the procedure gets more complex, the cooler you go for safety.
And Rick Hebeler, can you say more about the two-component transcatheter mitral valves via transeptal?
Are you talking about the CardioQ? I mean, oh, the case. Caisson. Yeah, I have no information about Caisson that I could really go into any depth about it. Just that it exists and it's being tried. Yeah.
So the question I have, having had a small amount of TAVR experience with transapicals, prior to the SAPIEN 3, we didn't find that the transapical thoracotomy patients did all that much better than a mini AVR through various options. Do you think that the limitation on the transcatheter off-pump mitral valves will be the same because the thoracotomy required for the transapical is fairly morbid procedure, or is it just because those patients are so much sicker on the aortic valve side that they didn't do all that well?
Well, the transapical aortic valve patients were done that way, and I think it was an index of what the burden of vascular disease was, because you couldn't do them any other approach, including direct aortic. So I don't think the comparison is exactly the same, but with the transapical mitral valve patients, these are people I've seen them. I don't want to operate on these people.
Right.
A conventional procedure. And then, with the functional ones, if you're going to put a valve in them, you're going to put them on bypass, you're going to do all that stuff, and yeah, we can do it through a right mini thoracotomy, but with the transapical, you avoid cardiopulmonary bypass and those issues. So I think, the Tendyne patients we've done have been great.
Clifton, there's a question I was going to ask too about the endoballoon. There's a lot of fear. I'm an endoballoon user from the beginning, but there's a lot of fear about the endoballoon. Some surgeons who used it in the origins of the hard port era, before we all knew how to use it, had a problem with it and decided they would never use it again. Others use a Chitwood clamp because it costs less. And the questioner is suggesting that perhaps a Chitwood clamp is easier. And so what are your thoughts about the endoballoon, having used it for now a number of years, and it's the routine part of your practice?
So there is a learning curve with the endoballoon, like anything. I think that it increases the complexity of preoperative thinking and planning, just like any minimally invasive approach. You can kind of flow through just about any operation through a sternal approach because you've done so many and you've got the heart there available and you can hold it and do this, that, and the other. If you're going to do it more remotely through the right chest, you really do need to know more about the vascular anatomy. And I think it's the complexity of planning that's really more the case. I think it's simpler because it declutters the field. The Chitwood clamp hits Richard in the stomach, which irritates him, but it just gets in the way in the robot arms. You can injure things with it just as you can with a balloon, and then you have a hole in the aorta. So I think in the end we have sort of fewer steps when we get to the meat of the operation, which is on the heart. But it does, you have to think more through who you should and shouldn't do. The other comment actually was with Steve was talking about, I mentioned we don't cool, but we do cool sometimes. And I did cool when I started, and it is a mistake to go warm until you can go quick.
For my own comment, the newer endoballoon is a dramatically improved device versus the original one, since I used both. And once you position it, it stays where it's supposed to go. It doesn't really require as much manipulation of the pump and careful with the perfusion pressures, et cetera. And so that I think that's another aspect that Edwards really has improved the device.
Well, I think that's true too. And we are, the first couple of times we used that 12 years ago before we did robots, I mean, there was blood on the walls. I mean, it was an ugly sort of deal. And there is a learning curve to any of these issues, and it is a two-man approach. And, I hear all the time, well, I want to do this and that, and I don't like the robot because I want to be in control. And if you think you are the one person in that operating room that is in complete control, you're really lying to yourself. You're dependent on everybody in that operating room. I'm very dependent on the echocardiographer, the perfusionist, my PA, when we bring the balloon up, and it is a real dance when you do that. But if you learn, it's simpler.
Dr. Bechara, there's a question. How long do you think before zone 0 stenting becomes routine?
It's going to be a while. Like I said, some people are doing it, we're doing it, but I think the Achilles heel for all these arch, not just zone 0, is going to be stroke. Until we figure out how we can reduce stroke, and now with this new proposed classification, that's going to hurt all of us in clinical trials. So I know there's a lot of research being done on protection devices. Some people even proposing reversal flow during those procedures. For zone 0, it's going to be a while before we have it as a routine. I'll probably say 5 to 10 years at least.
Clifton, you mentioned that you don't cool. You mentioned you never see unilateral pulmonary edema. I think it's because you're really fast and your team's all honed and clicking every day. But it still is an issue for a number of programs, particularly new programs in prolonged procedures and in patients with pulmonary hypertension pre-op. Just recently, I know Doug Murphy and Manny Moss reviewed their experience from Atlanta, discussing how prior to establishing a number of specific techniques to prevent unilateral pulmonary edema, they saw 1%, 1.6% incidence, and then after establishing routine cooling, higher systemic pressures, no CO2, no heated CO2, and minimizing lung downtime as a standard approach, then they didn't see any of these. How does your technique compare with those various ideas?
Well, we violate just about all those rules except the high systemic pressure, which we believe in. Early on, remember, we thought it was a PA vent, and we thought it was bronchial artery flow. I have seen it as a radiographic curiosity in 2 people. I have seen it as a clinical event with mortalities, not in my patients, but in 2 partners I was trying to train. They were new, and they were rough operations, prolonged pump runs, and a lot of struggling. And I think that it's long pump runs. I think a lot of CO2 under pressure when you're on pump is really bad for the lung for some reason. I think CO2 under pressure can help you. I think heated CO2, helps you because you don't have fogging and it helps you move. But to be able to do this, you've got to have the choreography, and you've got to be extremely simple, and you've got to declutter your operation and declutter the field. And I think if you can do that, then I think you can get away without it. But I do think if you're learning, I think, we were taught to go cold to protect the heart and protect the patient from the jump when we were heart surgeons. I don't think I think that's good lessons. I think you ought to cool. Cooling when you get into trouble usually helps you. My message was really for that you can do it in a routine and an efficient manner, but not necessarily before you learn. I think that what he says probably makes sense when you're starting. I don't know if it's necessary in all cases.
Okay, we have one final question, and then we're going to have a 10-minute break. Will transcatheter techniques ever replace mini thoracotomy and robotic approaches, Rick?
Ever is a difficult question, but currently, no. And, with endocarditis, I can't see that you're going to be able to do something with a catheter that will correct that. We can do some pretty complex reconstructions and fix many patients with endocarditis. One of the other things with these techniques, and they're early, granted, and they'll get better, but they require a lot of fluoro time, some of these techniques, and that means you're radiating the patients and you're radiating everybody in the room, including yourself, and the more of these you do, there's a cost to be paid for that as well. So some of these devices, I think, will prove handy for us as well. And again, the reoperation for somebody with tricuspid regurgitation has a significant mortality. So these may be great devices for helping people that are not candidates for surgery. Like anything else, we'll start with the patients that nobody wants to touch. They've got all the little dents in them from the 10-foot poles. And then it'll start moving down as we can see that we can treat the sick ones. Why do you want to treat them? You treat the healthy ones. And I think we will see more and more of this. But they are techniques you're going to have to learn.
All right, we're just a little behind, so we're going to take a exactly 10-minute break and then begin with the next session on aortic valve procedures.